Hello to everyone on the line. We're going to give just a couple more minutes for people to get on here, but we will be starting just momentarily. Okay, I think we'll go ahead and get started. We might have some people trickle in, but we'll go ahead and get started. So hello, everyone. I do want to welcome you to our transportation and health panel session. And we're really excited to be hosting this. This is hosted by the Southern District's Young Member Committee. And this is a session we've been working on for a while now. And so we're really excited for the lineup that we have, and then also just for this to come to fruition and to be sharing this event with you all today. So in the Southern District President, Cindy, she asked the Young Members Committee to host a technical session, and she had asked this a few months ago, and immediately the topic of transportation, health, and active transportation, it immediately came to our minds because it is becoming so important and so prevalent in our practice today. And really what once was limited to, hospitals and gyms is kind of how we thought about that health aspect, but it's becoming so integral in how we approach our transportation policy, our planning, our design, and really how it affects our communities. And it's something that we really do need to take into consideration, and it can't be hiding in the background anymore. And so we're really excited to share this lineup with you. We've got some great presenters on the line, and we'll let them each go through their presentation, then we'll have a Q&A session at the end. So before we get started, I have just a few housekeeping items and announcements to share with you all. So first, I do want to let you know that the session is being recorded, and we will be making that available through some platform to be determined after this webinar, but the session is being recorded today. And for those of you who need PDHs, the PDH certificates will be sent out this week after we verify the attendance. So be on the lookout for those, and those will come through the email that you registered for this event with. So quickly to touch on the Q&A portion, as I mentioned, we will be holding all questions until the Q&A period after all the presenters have had a chance to speak. But we will be using the chat box for that feature. So feel free as we are going through the presentations, if something comes to mind, feel free to go ahead and put that question in the chat box, and we'll just be saving all of those then for the end. And one of our wonderful Southern District Young Member Committee members, Melissa, she'll be monitoring that chat box throughout the presentations and then monitoring that Q&A period. So again, don't feel like you have to wait until the end to ask your question. Just know that we will be addressing all the questions we get throughout the entire session. at that end portion. And on the international level, if you're not aware or familiar, there's a lot going on within international IT around that transportation and health topic. And so I really encourage you to, beyond what we're going to talk about today, to check out the Transportation and Health Standing Committee. They host and monitor an e-community on IT's webpage. So definitely go and check that out. They've got a lot of great discussions going on there revolving around the transportation and health aspect. And the committee actually does have a meeting tomorrow at 1 p.m. That's Eastern time. And I'll put that information in the chat for anybody who's interested in learning more about that committee or attending their meeting tomorrow. Again, that's at 1 p.m. Eastern time. And I'll drop that link in the chat once we get started with these presentations so you can join. And lastly, I do just want to mention Southern District's next mentoring session, and that is called Successfully Navigating the Last Half of Your Career. And if you haven't been following these mentoring sessions, this is the third or fourth in the series that Southern District has been doing, but they've been really great sessions. They've been similar style of panel discussions, and they've been some really valuable information. So I definitely encourage you all to check out that next mentoring session. And that's happening next Wednesday, so just a week from now, and that's over the same lunch period time. So check your inbox. I think they sent out an e-blast recently, and it's also been in the Southern District Connector. So if you're interested in learning more on that, definitely check your emails. So with that, that's all the housekeeping items I have today. Again, we really hope you enjoy the panel session today. We've been really excited to listen to these presentations and to host these presenters. And so with that, I'll hand it over to another one of our fabulous young committee members, Michael Joyner will introduce our first speaker and the speakers thereafter.
Thanks for that introduction, Noelle. So like Noelle said, we're going to be running through each presenter and then holding the questions till the end. I will be introducing each speaker and then give a brief bio of each speaker, and then we'll roll into their presentation. And then once they're done, we'll do the same thing for the other ones. So the first speaker we have today is Tyler Johnson. His presentation is titled Healthy Mobility, a Tool for Healthy Communities. Tyler currently works for VHB as a senior community planner in Orlando. He currently has 10 years of experience and is a graduate of Tufts University. He is originally from Maine and hopes to run a race in every state. And with that, Tyler, go ahead and do it when you're ready.
Perfect. Thank you, Michael. My screen's popping up there now for everyone to see. Yeah, like Michael said, I'm a planner by trade. I'm not a expert in public health. There are more folks that have that experience on this call that know more about it than I do. But I just want to say, I'm happy for the opportunity to talk to you all today. And I'm just going to kind of go over the why, the what, the how, and the where. So really the why as planners and engineers, we at VHB are looking at this, the what we're doing about it, the how, kind of a little bit of the background, and some examples of where we're using it. So I'll try to keep it high level. I don't want to put any of my other panelists up here in a time crunch at the end. So happy to answer any questions at the end if I seem to skip over something. So just to start, we started working on this, really looking into healthy community design and everything in terms of planning and what we're doing in community master planning and transportation planning down here in Orlando in Florida with VHB. Now it's been about 5 or 6 years ago. This is just one of those charts. I'm sure everyone's seen stuff like this, but basically, the trends in chronic diseases. This is just showing obesity in the country. We're getting worse. Diabetes is another one there. And then, these are just, numbers that we found from our research and talking with experts in the field, about how much, we're spending per person as a country on this, and what that's doing to us in terms of, early deaths, and how much money we're spending and how much could be saved just if people started walking. And that's really what got us start thinking, okay, well, how do we as planners, how can we help address this? We're not doctors, we don't give the care, but how really that idea of how we design our communities and plan our communities and plan those transportation systems can have an impact on the better health for the residents of the communities in which we live and work. Right. So, first off, what factors determine, family health history? Not much we can do about it when we're planning communities. Behaviors and lifestyles, that's one we can start looking at. How do we make it easier for people to live healthy lives? For instance, back in '74, 2/3 of children walked or biked to school. And then, in 2019, it was 10%. Part of that is safety. As a parent, I, think about that with my son as well. But part of that is just, it's not possible now. Schools are too far away. They're busing kids too far. We haven't really worked to build communities around the schools. So that's just kind of one example. And then finally, the built environment. This is really where we start looking at how what we do every day can impact people's health. So that was really the one thing. And really it gets into, public health is no longer only the business of health professionals. One of the folks we've worked with a lot on this is Dr. Richard Jackson out of UCLA. I think he lives in Berkeley, but is at UCLA. But he literally wrote the book, Designing Healthy Communities. And he's a physician. He was at the CDC, but he liked to say, when we met with him and when we were presenting with him, that as a doctor, you're treating the symptom, right? There's the cause of the behavior, the lifestyle, the built environment that all have, these long-term effects on people that are seeking care later on down the road. So how can we look at it? So what we did, we really wanted to get into the data, right? It sounds like it makes sense. The more people walk, the healthier they are. That sounds great. There is research. The more people walk, the more people can bike, the closer they are to transit, the more mixed use they have, the healthier or the lower their chances of obesity, and the lower the chances of obesity, the lower the chances of high blood pressure and diabetes and all that that comes with it. But we really wanted to look at, when we look at the built environment, how does that factor into our decision making as we're making plans and prioritizing improvements and looking at what limited funding municipalities may have for some of their capital improvements? How do we direct it to a way that has the biggest chance to kind of move the needle in terms of positive impacts for the community's health? So this really just is the idea of healthy community design, looking at, like I said, how we design and how we plan affects people's lives. So we brought together experts from the field, departments of transportation, universities, healthcare professionals for 3 kind of symposiums. This was just really to listen, to kind of get an understanding of what was out there in this field, and kind of give us that baseline. And really what we learned was, there's lots of, success stories. There's lots of anecdotes. There's that recognition that, they are connected, but there was really no consensus on how do you obtain that data for this level of community planning. When we do an existing conditions analysis, we would like to know, well, what's the health risk for the population in this area? And that's, we found that was challenging to get. Even working with hospitals, it was challenging to get. They have different service areas than, a community, a neighborhood, a corridor study or something like that. And there were no models readily available. There were 1 or 2 that had been developed, but they were more kind of academic and hadn't been really used in the real world when we were going through this. So that's really what we wanted to start doing was, okay, how do we take these principles of healthy community design, mixed use development, access to food, access to parks, take it with the data that we have that's available in terms of, census and GIS based data from municipalities, and how can we create a model that would actually help us model these relationships? So really we wanted to analyze the land use and mobility factors, built environment factors, to really get that baseline assessment. So I'll get into kind of the 2 different levels, but really get a baseline. Like we do with transportation planning, we want to know how many cars are on the road today, right? We want to know how many cars are turning left, turning right, environmental, where are the wetlands, that sort of thing. This is something that we wanted to just bring into from the beginning of our planning process, understand what's going on in terms of the health of the community. And then we wanted to be able to project out, forecast likely outcomes, look at some trends that we can get for these areas, and really look at what of those factors, be it a new bike lane, additional sidewalks, maybe it's a new park, maybe it's just something with the land development code to allow mix of uses, but what would have the biggest chance to help the members of the community, and use that as a way to not only make recommendations, but help our clients, prioritize and rank, potential improvements or funding for projects. So we split it into two levels based on data. So one is just, we'll call it tier one. This is based on census data. The CDC had a, I guess they still have, but they had a 500 cities data set with 500 of the largest cities. They've since expanded it to, I believe it's everywhere. But when we started this, that's what was available. So we used six of those chronic diseases you can see on the screen, and we related it to about 150 different census data points. So demographics, education, commute mode, commute time, labor force participation, housing quality and affordability, everything that we could get from the census, to put together basically a projection for each of those diseases, which we can then combine moving forward to kind of give an overall risk, or we can look at each disease individually. So really, I'm not going to worry about any of the text on there. You can read it if you want, but really what we started was, we started in Florida. What you can see on the screen were the cities that the CDC had data for when we started. And then what we were able to do was basically use that as our control, run all the regression analysis. We worked with a professor out of USF, who is a professor of economics and statistics. With his doctoral thesis was actually on public health and doing this. So we worked with him to make sure that, what our model and everything was valid. And we've since expanded it to the whole country, or to the whole Eastern Seaboard, I should say. We haven't done the whole country. We have the data for the whole country. We just haven't run the analysis at this point, but we could. And what we've done is, we can see that we just have it showing as low risk, high risk, or medium, based on, you can either base it on the state, base it on the county, base it on a specific project area. But really, this is, it's not quite getting into the weeds of, is it 23% obesity or is it 23.6%? These are still kind of projections based on some of those behavioral risk factors. So we keep it at, we like to keep it at this level, but this is a screenshot of an app we developed to basically, if walk score, where you can zoom around, you can click on your neighborhood, and you can see your walk score. This is similar. It's based on census tract level data. That's what we were able to get. So that's what we have to relate everything to. But you could zoom around, Florida up to Maine. And we're building it out for the rest of the country as we have projects that come on. But you could zoom into your neighborhood, you could click on your neighborhood, and you could see what the risk factors are, and how it relates to areas around it. So this is just a screenshot of one of our projects up in Massachusetts. So in Connecticut. So you can see, all of New England. You zoom in further, and you can, start seeing in different towns and different cities where the high risk areas are. And that's really what this first level does. It is a geographic kind of distribution of the location of those at-risk areas, based on the census data for chronic diseases. The next level, this is where we really start tailoring it to a project or to a study area. We still include some of those social determinants: income, employment, race and ethnicity, housing affordability, commute mode, those sort of things, to make sure that we have we don't bias our results. But this is where we can start adding in kind of location specific information. So bike lanes, are they separated bike lanes? Are they not? What's the lane? What's the width of the roadway? How long is the block? Where's the parking? What's the tree coverage like? What's the density, location of community gardens or schools or anything like that? This is really where, if we can get the data and normalize it to a census tract level, we can run the analysis, and we can look at how each of those data points relates to those chronic diseases we looked at. So we can start saying, okay, well, these have statistically significant, correlations when we look at the study area and we look at everything to the health in the area. So that's kind of where we really start seeing, okay, what improvements can really, lead to some pretty significant change in these areas. Once again, they're still projections. It's that whole, field of dreams. If you build it, you know, they will come. Well, not necessarily, right? We could say we've had ones where bike lanes show up. You can build bike lanes, but if there are other reasons, you know, why folks don't use the bike lanes, you're not going to see that projection. So what this is showing is it's showing what the relationships are, and that's what we can get from this to try to help you know, inform our decision makers moving forward. Just a couple quick examples of where we use this. You know, this is just it's a chart, but it's basically, we were doing a trails master plan for Orange County, Florida. And we just had it as a scoring criteria. So in addition to looking at, you know, environmental justice, in addition to looking at available funding, in addition to looking at how it connects to the rest of the network, looking at the community health was one of the prioritization factors that the county wanted. So they wanted to see, and they were giving higher scores to trails that kind of went through areas that were at high risk for these diseases, to basically increase access to the trail system and the destinations there and help that. So it wasn't, you know, the end all be all of decision making, but it was one of the factors that played a role. And we're starting to see that more in our projects, both down here and up in New England, in terms of some of these our metropolitan planning organizations and some DOTs starting to look at incorporating health as one of their factors. This is downtown St. Petersburg. I'm going to just quickly go through this, but we were looking at a potential redevelopment of the Tropicana Field site. We looked at, you know, some of the factors in the area, and, you know, in this area, it was, we found that it was access to, you know, walking access to grocery stores and healthcare providers had the highest rate, as well as, you know, areas where parking was behind the building. So, you know, around the baseball stadium, there's lots of parking, lots of large parking lots, but really those areas in downtown St. Petersburg that had kind of that more walkable urban feel had better health outcomes. And then in addition, this was the one where the code, the land development code, actually prohibited some of those mix of uses of bringing, you know, small food stores or healthcare providers into some of the single family neighborhoods. So that was one of the recommendations, was to you know, take a look at that and see if the city wants to do something like that to incorporate maybe not full scale retail, but certain, you know, specified uses in areas. And finally, this is one that we did with MetroPlan Orlando. It's our regional planning organization. We worked on their long-range transportation plan for Orange, Osceola, and Seminole counties down here. And that was another one where we were looking at kind of that first level of, you know, well, what alternatives are they looking at? What kind of neighborhoods and the risk of those neighborhoods do they go in? And then they wanted to actually start getting into that second level of analysis. So this is West Orange County. You can see right down here in the southwest portion is where Disney's located. And this is one we were looking at, specifically access to parks. So we looked at that second level, and we were looking at, you know, well, you know, they were a stakeholder for a grassroots organization, and they were looking at, you know, what factors here in the mobility network can impact health, and specifically they wanted to know about parks. So we actually did find that access to public parks, not any park, you know, not any recreation, golf courses didn't help, access to, you know, private parks and homeowners didn't help, but specifically access to public parks in their service area did include it. So then what we were able to do is, you know, overlay the data on, you know, how people can get to those parks, what's the programming at those parks in terms of that sort of stuff, and you know, help them make decisions as to how they can enhance and improve that access. Just quickly here, you know, one of the things, just showing that this is just data and there's some interpretation. We did find that vehicle lanes and total right of way actually had opposite correlations in this area, and we really went into it. We reached out to some experts and making sure we were doing everything right. But what we found was a lot of the area, a lot of this green area down here that you'll see is a new master plan community. And they actually have wide rights of way because they have a rural drainage section. They have off-street bike lanes. They have wide medians between the two lanes. So even though the right of way was getting bigger, it wasn't being filled with more lanes for vehicles. It was being filled with wider bike lanes, wider buffers, that sort of thing. So that's where we found that kind of relationship. So in this instance, it was actually the wider the right of way, the better the health outcomes, but we had to kind of go and look at, okay, well, what does that actually mean? So basically, yeah, just looking at it, this is everything I've said before, but establishing that baseline, we've used it for neighborhood studies, we've used it for alternative assessment and prioritization of factors, corridor studies. We're working both down here in Florida and up in Massachusetts with departments of transportation on this, and finally the prioritization. And I'm going to stop talking now. I'm happy to take questions at the end, but I'm looking forward to hearing my co-presenters and everything that they got going on. So thank you so much for your time.
All right.
Back to you, Michael.
Thanks, Tyler. We're going to roll right into the next presenter because of time. The next presenter is going to be Mike Sewell. His presentation is titled Empathic Analytics Using Biometrics to Better Design Transportation Projects. Mike currently works for Gresham Smith as their active transportation design lead, and he is currently based in Kentucky. When you're ready, Mike, go ahead and start.
Okay, can you hear me okay? And you got my screen, I'm hoping. Okay, speak now or forever hold your peace. Okay, thank you for the introduction, Michael. Okay, perfect. And I'm gonna go kind of fast. I know we're crunched on time, and hopefully we have some time to talk about questions and things outside of this, but I'm here to present a new platform I've been working on for a couple of years called Empathic Analytics. A little bit about me, I'm one of the owners of Gresham Smith. I have two hats. One is primarily active transportation, so everything multimodal and completing our streets. And the second one is running an innovation incubator inside our firm where we invest about $1 million every year into new ideas coming from our employees. We incubate those. We hopefully can spin them up into standalone businesses. This is one of those ideas. This is mine. I will tell you, it won Architect Magazine R&D Award last year. And then it's also been picked up for a Geospatial World Forum where I'm presenting in Amsterdam here in about 3 weeks, centered on this. What is it? This picture is from Leiden, actually, in South Holland. I was biking across the Netherlands about 240 miles, and I had this epiphany that because I'm a very active kind of commuter, I have a car, I don't use it, I bike almost every day. In the Netherlands, though, it felt like every facility was built for my comfort and for my enjoyment. And I thought that was a very distinct difference from what I'm typically used to over here on the stateside. And so me being a professional engineer, I know that engineers like data, and I started really digging into how I could quantify that feeling. And the result was empathic analytics. And I'll go into a lot of the detail about how it's done and how it works and why it works. To my competitors on the call, this is patent pending. So if you want to use this or this approach, please reach out and you can team with me. Otherwise, we'll have to stick a bunch of patent attorneys all over you. Here we go. Why does it matter? This allows us, and to my understanding, this is the first platform that allows us to do this, is understand how users behave in certain context. And that's important because us as engineers, we design lots of confusing systems, a lot of things that are completely unintuitive that overwhelm everyone's senses. What comes out of that is mistakes, right? We have crashes. And the top right, we see some things that are laid out just don't function for how people want to use them. And the bottom right, we see this AASHTO compliant, everything checks all the boxes, but we see this user is not using it with the intended fashion. And in the bottom left, we have another user who's obviously contending with lots of other things. The last thing on her mind is walking to the end of this block to cross at a safe crossing. And so we're dealing with things that are not captured in AASHTO, not captured in even ITE's forward thinking manuals or NACTO for that matter. These are emotional kind of human behavioral issues. Why that's important and why I think we can do better as engineers is if you look at our traditional design process, at the front end, we're collecting lots of data about crashes, geometry, how fast people are going. We go to the public and we say, does this kind of capture what problems you think exist? And then we start kind of estimating what we think best practices would be that would fix those issues, right? We get to planning, and typically this is a cyclical process. We go back to the public, we say, hey, here's some ideas. Does this work or not? Yes or no? And then we go further through this. And sometimes we get all the way into engineering and realize that there's been a change. We saw this last year with COVID, right? We saw lots of different users out on our corridors identifying lots of new problems. Or we have emergent trends that are just not captured from that original data set. What I'm proposing is this platform kind of fills a critical gap in our design process where we can really use it to Better engage end users and identify what that experience is, their perceived safety, and then hopefully if we can collect enough data, we can start using it in a predictive sense. So instead of rear view mirror, which is what we do now, where a problem or where a loss of life has occurred, now we go and fix it. We can hopefully get to a point where we can prevent those from actually happening. And this is another reason why it's important. If you look at the Governor's Highway Safety Association, 5 of the top 12 issues are these right here on the screen. These are human error, human behavioral issues. These are not geometric AASHTO things that we can just look up in a book. If you talk to NHTSA, they say 94% of crashes are influenced by human error. Very much the same thing. We see FHWA now investing in emotional response and behavioral issues on our roadways. That's brand new. That's this year, that's emergent. So it's important. And I believe it should be important to everyone that is in responsible charge of designing infrastructure. How it works, basically I'm using heart rate as the basis and looking for nonlinear transforms in heart rate. What does that mean in layman's terms? It is the triggering of our autonomic system. It's the fight or flight mechanism where if you have something negative happen to you, you want to avoid it. And when I say nonlinear transforms, if I told Michael Joyner to get up from his desk and take off at a run, his heart rate would go from 70 in a very linear fashion up to 90, maybe 95 if he's a little bit out of shape, whatever. But if I threw a bear behind him, it's going to go from 70 to 90 in a very quick fashion, and it's more exponentially based. The exact same thing happens if you are in the built environment. If you're on a right of way and you step out into a moving car and they buzz you, or if you have a car that flies up behind you and slams on the brakes, this exact same biometric response happens in every roadway user. So while it was based on my experience as a multimodal cyclist, it can be done for pedestrians, scooters, bus traffic. It doesn't matter the type of user. That same autonomic system fires when we're in a stressful setting. How it works, we typically have a targeted stakeholder group. I've got, we strap people up with heart rate monitors that are capable of high polling data. Most modern wearables are capable of doing that. We correlate it with location data using GPS. All of my system has been programmed to tie directly into APIs for Apple, Google, Fitbits, Garmin's, you name it. So you can share that data directly to my platform and it plots out a plot of stress. What's cool in this is we can then begin to aggregate that stress data and show where users are exhibiting the most stress or different users are exhibiting similar stresses. Here is what the really cool dorky math behind it. There are 4 basic scenarios that bubble up every time we do an analysis. And if you plot problems along a corridor, so in this instance, it's crashes, and that can be bar charts, it can be whatever that happen along a corridor, and then you overlay human stress or emotional stress to that. There are 4 distinct scenarios that always bubble up. Number 1, where people are exhibiting a high level of stress, and there's also corroborating substantive data that says there's a problem, like crashes if you're a road safety person. That's kind of our standard engineering process, right? That's where we know there's problems. We know it doesn't feel right, but we do the full engineering services on those. The second scenario, where we have very low user stress, we have people feeling very comfortable and we don't have crashes. That's the sweet spot, right? That's what we want on every one of our projects. Going back to the first presenter, we want to create environments that are inviting, that people enjoy, that are comfortable if we really want to influence people's, kind of daily lives and activity levels. This is where my platform kind of really separates from the rest of the engineering pack, is where we have this scenario where users are exhibiting very high stress, but there's not substantive data to back it up. So we've got people that are freaking out, but we don't have crashes. We don't have any substantive data set that says there's a reason for that. And the fourth one, which is also a disparate value, where we have very high crashes, but we have people feeling very comfortable. These don't make sense to us, right? So I'm going to concentrate on just 3 and 4 kind of for the sake of time. So 3, where users feel unsafe and crashes indicate it is safe. This could be a really interesting scenario that usually bubbles up on almost all the projects that we record. This could be close calls, right? This could be an area where there might be a single fatal, but there's no trend that you can establish to justify a fix. Or again, if you look at fatals and how they work over a course of a map, they're most of the time sporadic. There'll be a fatal here, there'll be a fatal here. There's no logic to it until you start overlaying all of these close calls. This gives us an additional data set to say, hey, there's something happening in this location. maybe we should spend a little more time. I know there's not crashes. I know we don't have any recorded substantive safety issues, but something's going on. And at least it gives us a little more quantitative approach to how we approach the planning and design process centered around safety of users. And the fourth one, where users feel very safe, they're low stress, right? But there's lots of crashes. This could be something where there's an emergent thing happening that we just don't fully understand from a user perspective. So maybe recently there's been a lot of landscaping installed. The landscaping makes people feel very comfortable. That's also created a lot of new blind spots or something like that. This potentially could be really easy kind of fixes. It could be low cost fixes, but the potential to save lives in this zone is just, this is where we have the opportunity to really save people's lives immediately. So that 3 and 4 scenario, pay attention to that. I'm going to play this video and see if I can get this to work. Oop. So this is the actual platform. It was programmed initially in MATLAB. I went through 3 different iterations. The base of it now was written on Python with an open source mapping called Kepler. And we see here there's 5 people walking. This was a project in West Tampa where they wanted to analyze pedestrian safety and stress. And we see that the user stress is starting to kind of show up as a heat map. The cool thing about the mapping software that I'm using in my program is you can display this data in lots of different ways. So here it is, bar charts. It also can be displayed on a timeline as well. So if you want to just focus in on what the average stresses are for a specific user group in a specific area, you can kind of isolate those. The other really cool thing about it is you can overlay substantive data sets so it can draw correlations between stresses user exhibiting and real problems that historically we know exist. The other cool thing that we can do in it now is also calculate dwell time. So where we have people spending an inordinate amount of time in a very stressful situation, we're finding that issues kind of compound for those users. So again, going back to trying to be predictive, we don't want problems to exist. We can take a look at multiple different things that this data is telling us to really proactively fix issues, which is what we all want. I think that's it. Now you have to watch the rest of the video because I talked too fast. And I think I'm going to change the background so it doesn't just have to be this slick background. You can change it to lots of different things. You can click on it and get interactive maps or interactive data from it. And you can also change the way it aggregates data. So if you just want a specific user group, if you just want an aging population, or you just want a junior level person, you can pull out those averages for just that specific age group. So it's pretty diverse, or it's pretty, you can change a lot of the different views in ways it's calculating user stress in this. Okay, benefits, lessons learned. And again, I know I'm going fast. For the first thing, I think it's really important because this is the first platform that really gives us those insights, real data on how users are feeling in space. This is great because it can fill any substantive data set gaps that exist, such as historic crash data or with emergent trends or currently what's happening. And it accurately will measure perceived safety via stress. And it provides that critical correlation between nominal and substantive safety issues that might exist on our roadways, which up to this point, it's kind of been a mystery. So that's really great. Number 2, and I mentioned this before, but we really want to get to the point where we're using this in more of a predictive sense. That's very important and because it could allow us to prioritize our projects. Now we're using it for prioritization currently, where we have, let's say, a planning study or an area-wide study. We can use it to start prioritizing high stress locations versus ones that have, maybe a minor amount of issues. These are things that we could probably prevent if we move those up into prioritization, which is very, very important. And lastly, building advocates. I eliminated a couple slides just to save room, but building advocates, I think this has gone over really, really well. Every time we've just been completely transparent with the public and said, or council members or whoever's on the stakeholder list. Here's what we're talking about, is user stress. And this is going to measure where you freak out, and then we're going to come talk about it afterwards. We take all of this data, or we take a group of 20 out to walk a corridor with running my platform, and we take that to the public. just eyes open up, and it goes from this angry hatred for what we do as engineers to, okay, I really get it, because when you put it in terms that make sense to me, I can be more supportive of the process. And when you say 90% of folks are really nervous at this location, can you tell me about this location? It makes it way more easy for them to recall, because we ask a lot from our public, you know, can you tell us all the issues that you've had over the past 10 years along this corridor? People are terrible at that. I'm terrible at that. But when you give them some basis that really means something to them, it really can lead to kind of a nice jumping off point for real insightful conversations around a project. And lastly, I don't mention this, but it's cheap to do. It's inexpensive data that we can pull. It's kind of passive, so we're doing it with kind of our road safety audits or walk audits at the beginning of the project, even pre-scoping for some clients. We're starting to roll in the insights the platform is telling us into the scopes for our projects that we're working with DOTs, and they build the request for proposals around some of these insights, and that's really what we want to see. Next, for the platform, we're entering into, and I did not do this by myself. I initially did all the programming, but I'm a professional engineer, master's in structural engineering, if that makes sense. I do not know much about the human kind of psyche and our response for human emotional responses to the built environment. So I've had to team with a lot of smarter than me people. One of those is a partnership with Vanderbilt University. Now we're looking at an area-wide study where their biomedical professionals and their psychologists are going to be working hand in hand with engineers to say, here's what commute traffic looks for the student base. And then start to partner with places like TDOT, who owns a lot of the state routes around that location, to really gain better insights about how we can fix just big barriers on our transportation networks. And lastly, we also have developed kind of an AI-centered AI is what we're calling it, EYE AI. But it's based on video input, and then we train it to look for certain things. So we can train it to look for maybe a visually impaired pedestrian, and how long does it take them to get from one zone to another? And then we're coupling that with my empathic platform and empathic data insights to really gain a far better understanding of what it takes for that user to navigate a specific, maybe tough situation. And then it allows us to better react to it from a design perspective. So that's the whole platform, and I look forward to taking your questions at the end.
All right. Thank you, Mike. Our next presenter is going to be David Ederer. His presentation is called Beyond Collaboration, Incorporating Public Health Principles into Transportation Practice. He currently works for the Centers of Disease Control and Prevention, where he works as an Epidemic Intelligence Service Officer, and he works in obesity prevention in the city of Atlanta. He is a graduate of Georgia Tech and has picked up fly fishing during the pandemic. And with that, David, you're good to go as soon as you are ready.
Thanks, Michael. I appreciate the introduction. So I'm actually going to be presenting on stuff that I thought about and worked on during my dissertation at Georgia Tech. So none of this is representative necessarily of CDC's view. I do a lot of interesting work there that I'd love to talk to anybody about. We use a lot of really cool big data thinking about obesity and chronic disease and how land use and transportation are influencing it. But today I actually want to kind of give you an introduction to public health and convince you that as transportation engineers, you are public health professionals, and maybe talk about how you can solve public health problems in your practice, and show you that transportation engineers have actually been public health professionals for a long time. So with that, if anybody can name who this person is, I will buy you lunch. And I'd be super impressed if you did name who this person is. But if you can do it, you'll blow my mind. So this is actually the first director of CDC. And the first director of CDC was not a medical doctor, was not an epidemiologist, someone who didn't even attend the School of Public Health. His name is Mark Hollis. He's actually one of 2 CDC directors that was not a physician, and he was the first one. And he's actually a civil engineer by training. Unfortunately, he went to UGA, Georgia Tech. But public health and engineering have actually been part and parcel to each other's work for a very long time. So back in the 1920s and 30s, there's this robust debate about what a public health engineer was. And so public health and planners, public health professionals and planners frequently note their kind of shared origins. It's, you hear the story of John Snow and the ghost map, but what a lot of people forget is that John Snow identified where cholera was happening, but had to work with civil engineers, namely Joseph Bazalgette, to build London's water system and solve the public health problem. So way back in the 30s, they're saying public health engineering is actually its own field. And the prime object of it is to control the factors of the physical environment as they especially affect the health and welfare of aggregates of people, whether in small groups, cities, states, special areas, or the nation as a whole. That sounds a lot like what we do in transportation to me, right? Manipulating the physical environment, and especially considering the health and welfare of the people that live in it. They went so far as to create a curriculum for the public health engineer. You can look at it here. It looks a lot like the curriculum we had at Georgia Tech for our transportation systems engineers. They have 2 semesters of transportation engineering in their 3rd year and take a pretty similar suite of courses to other civil engineers. And again, I really liked this quote here in the American Journal of Public Health, because it really, I think, highlights the point of this presentation and a lot of the work I do. So it's not so important that engineers know how to build a sewer, as that they know why sewers are necessary and what results may be anticipated from the discharge of their contents without treatment into a body of water. We could flip the topic to be about roads and transportation, right? It's not just important to think about how we build roads, but why and what happens when we do so. And I'm going to frame this in terms of safety, because I think there's a pretty clear connection between public health and safety, and everything else flows from that. If we don't have safe roads, we can't do things like be physically active on those roads and help solve chronic diseases. So the traditional engineering approach is kind of this EASE framework, right? You've probably heard of the 3 E's if you've worked in transportation safety, right? Education, enforcement, engineering, first proposed in the 20s by the National Safety Council and other traffic safety organizations. They continue to be used today. You can look at NHTSA documentation. It's right there in their strategic plan. So over time, we've actually added E's, right? We have evaluation and emergency response and equity, right? All these things, all these E's are important, but just kind of putting these E's out there and adding alliterative terms doesn't really tell us what causes a crash or say anything about public health, right? It's kind of an outdated framework. So I encourage you to think not just like engineers, but epidemiologists. So here's a basic way that epidemiologists think about the world, okay? So they have 3 things: the host, the agent, and the environment. So all 3 of those things need to interact in some way to cause a disease. And to prevent disease, we break that triad, right? We interact to make sure those 3 things do not affect one another. And of course, we've added the social determinants of health to put context to all this. But think about malaria, right? So the human being is the host. The one human being is likely to get malaria when they're maybe in a wet or swampy area where a mosquito might be, and the agent is actually a plasmodium parasite, right? So you can intervene by making sure people don't go to wet, swampy areas, right? And you break the host environment triad. You can also intervene in the environment. You can drain those wet areas and make sure that mosquitoes and the Anopheles mosquitoes and plasmodia can't thrive, right? You can also give people medication that changes the agent and kills that plasmodium that causes malaria, right? So we can think about this in transportation. So around the same time the 3 E's were developed and promoted, epidemiologists began to think about injuries, right? So energy is the same thing as a virus in this case. It's what causes an injury, right? And we can come up with interventions to change the interaction between energy and human beings, like 3-point seatbelts, right? It distributes the force in a crash over tougher parts of our body so that all that force is, it doesn't go to our forehead, right? We don't hit the dashboard. It's actually distributed over our waist and our chest and our sternum, which is much more powerful than other parts of our body. We can also intervene in the environment, change how human beings interact in the environment, tell them what a safe and reasonable speed might be. You can also change how energy interacts with the environment. We do this with things like vehicle design, right? We have roll cages and crumple zones to change how those vehicles absorb energy. We can do this in the built environment as well, right? A roundabout is fundamentally different than a regular intersection because we change how force is transferred in the environment. And this is actually really key to the work I think you do and many people are doing in transportation right now, and specifically with Vision Zero and safe systems. So I'd argue that public health the public health mindset is at the center of this approach. And this is straight from FHWA. So I'm going to show you that this is real public health thinking at work. So it's not just about preventing crashes, right? That's the old way. It's about thinking about those health outcomes, thinking about injuries and deaths. And it's not just about human behavior. We actually consider the fact that humans are imperfect and we don't assume ideal behaviors. We actually try to reduce the harm that's involved from those human behaviors. We think about system kinetic energy. That thing that actually causes energy is the focus of all these policies. And we move from just thinking about individuals, like a doctor might, to thinking about populations, like a public health professional does. And you don't just look at crash histories, you try to proactively identify and address risks before they ever happen. So these are all ideas that are really critical in public health. And if you go to school for public health, you can see how these ideas are prevalent in the work we do in epidemiology and public health. And this isn't a mistake. So the person who came up with Vision Zero, or one of the safe systems philosophies in Sweden, was actually not an engineer. He was an epidemiologist by training. And this is how he thought about safe systems and Vision Zero. He thought about it as a public health intervention. So not just thinking about how we influence health, but how we think like public health professionals. And safe systems approach has been very effective in many countries around the world, New Zealand, the Netherlands, the UK, Australia. And really it's a paradigm shift to thinking really like public health professionals. And so there's a nice document from ITE, and I borrowed this presentation from, or this slide from a prior ITE presentation, highlighting those kind of public health ideas. We focus on that kinetic energy, right? And we try to align functional classification with design and speed, because speed is how that energy can be realized in the real world. And so we try to manage latent risk in the system rather than just focusing high crash locations. So how can you incorporate this in your work? I'm so glad that other people have that mentioned the Netherlands, because I think they really get this, and they distill their safe systems principles into really kind of clear design standards and clear ways of thinking about transportation safety and how they actually recognize it in the real world. So these are their 5 initial principles of sustainable safety. That's what they call their safe systems approach. So first one is the functionality of roads. So roads should really have specific functions, and they should be designed in a specific way. So we have that kind of confusing thing called an arterial, and you can have a 2-lane arterial in an urban area that's very, very different than another 2-lane arterial that's in a rural area and that functions in an entirely different way. They kind of simplify things. And this is really based on the idea that one needs to have homogeneity of mass and or speed and direction. So this is about transferring force. Kinetic energy is the key, right? So they try to make sure that the causal agent of injury is considered when they're designing things. We could talk about this for an entire technical session, but what does this mean in practice? And this is a slide from Professor Peter Firth at Boston University. I really like how he described it and kind of applied it to the US context. So he thinks about, or what the Dutch, they think about the critical vulnerability when designing their roadway. So if you're looking at a local street, a neighborhood street, where people can cross anywhere and you might have bikes and mixed traffic, you don't just have a design speed, you have a target speed. Great engineering means you can not just allow up to a certain speed, but engineer the system in a way that people travel and feel comfortable at that correct target speed. So if you have that unlaned local street, you have things like speed bumps, maybe stop signs, neighborhood traffic circles. If you have unsignalized crosswalks, but you have to separate those lanes, you have your target speed at 25 miles an hour, you incorporate crossing islands, which make those left turns safer and offer a little refuge as people are crossing the street. If you have that potential for cars to collide at right angles, those multi-lane roads with traffic signals where you want people to travel at 30 miles an hour, you need to program those traffic signals to limit speeding opportunities, right? And you have to use actuation, shorter cycles. You limit coordination between those shorter zones. Instead, you try to get people to travel more slowly. This is really all about thinking about conflicts, not just hotspots. What does that mean in terms of functional homogeneity and thinking about how we define function in the sorry, not the motorway, on roadways. So the Dutch think that roadways shouldn't have competing functions, right? And you could take this map and apply it to anywhereville in the United States, and you'd have lots of other colors because we actually break down our functional classification system much more than the Dutch do. And so they try to really incorporate the complexities of human behavior and understand that people are going to make mistakes. They don't try to design out mistakes. They try to design the road in a way that those mistakes aren't fatal or cause a serious injury. So they limit speeds and promote mass homogeneity. That's thinking about kinetic energy as the cause, like a virus, right? So in the purple, you see a through road. That would be kind of like our grade separated highway. So there's no interaction between people walking and cycling or traveling at lower speeds and lighter vehicles and people driving in cars at high speeds at all. This we do pretty well, right? We don't have too many people walking or cycling on our highways, but it really gets down to those orange and green roads, those distributor roads and access roads, where the Dutch kind of have more rigid design guidance on how and whether people should interact. So on those orange roads, those distributor roads, the function is to kind of get people off the through roads and then deliver them to the access roads where they can get to their destinations. And on those distributor roads, you're likely to have that actual separation between people walking and cycling and people driving. That's where this famous Dutch cycle paths appear. And that's based on the idea that more force would be transferred if they were to collide. And the speed at which people travel in cars on those distributor roads determines the level of protection for people walking and cycling. And then in the green roads, you actually have mixing of traffic. Actually, the first slide from Mike's presentation is a good example. You have this safe, comfortable, slow road. I actually love that design that was pictured there. It's one of my favorites and something we can apply in the United States. So that's where you'll see people walking and cycling without separation. There's a lot of really great Dutch engineering where there are no separated cycle paths. They just are interacting with traffic, but is driving much more slowly. So really, conventional safety practice looks like this, right? We assume driver error, and then we try to design it out of the system, right? You talk about behavioral economics, or Mike was talking about behavioral economics and thinking about how people think. We need to get away from the idea that we can design out driver error. Driver error is going to happen. What we need to do is understand that there's this much bigger causal path in how people make mistakes, and that people are going to make mistakes for all sorts of things, which can be organizational, environmental, whatever it might be. As engineers, our job isn't necessarily to design out those mistakes. It is to design a transportation system, a safe system, create latent conditions that allow for those mistakes to happen without people dying or getting seriously injured. And I'd argue that is the public health approach. And going back to Tyler, bringing up Richard Jackson, who is a great public health hero of mine, creating a built environment, creating a transportation environment which allows for people to do things like walk and cycle and be healthy and not be killed and injured in crashes. So I look forward to your questions. Here's my email. Feel free to contact me. Lots more to talk about on this stuff, but really excited to hear from Chris. So thanks so much.
Thank you, Dave. All right, getting into our last speaker. Hopefully we can make through this without running over. We have Chris Rome. His presentation is titled Active Transportation and Vision Zero in Atlanta. He currently serves as a senior multimodal transportation engineer for the City of Atlanta Department of Transportation. He currently has 11 years of experience and holds a Bachelor of Science of Civil Engineering from Louisiana State University, and also holds a Master of Science in Civil Engineering from Georgia Tech. His hobbies include cooking, backpacking, bicycling, hydroponic and outdoor gardening, and chili pepper fermentation. And with that, Chris, take it away when you're ready.
Thanks, Michael. Homemade hot sauce, that is what keeps me going every day throughout the pandemic. So just keep that in mind. I really enjoyed the presentations from Dave and Tyler and Michael. And now I kind of want to go through what a little bit of the application of some of these ideas looks like on the city level. So first, I want to talk about the City of Atlanta's health goals. Sorry, skip the slide. And so first we'll talk about a brief kind of summary of plans and programs that the city has adopted to further health and roadway safety. So the first kind of overarching guiding document that we use as the City of Atlanta Department of Transportation is our transportation plan, which was developed in 2018. It was adopted and it's guided by three main goals: safety, mobility, and affordability. More recently, we've changed this third kind of primary goal into more of an equity focus. So, future project lists will all be evaluated and prioritized using a scoring model that we're calling our SEM model: safety, equity, and mobility. But today, I'm going to focus on the safety and health goals for our transportation system. So as the previous presenters mentioned, we know that we can get our citizens to use active modes of transportation as a primary goal to improve public health. So there will be, public health benefits for both individuals and the environment with reduced emissions. So in the City of Atlanta, currently about 54% of people drive alone for all trips. That's not just commute trips. It's all trips, 54% drive alone. And our goal for the future that was outlined in our transportation plan was to reduce that amount to 35% and increase our active transportation mode share to 35%. The current active transportation mode share, walking, biking, and transit is 17%. So we're looking to double that number to garner these public health benefits. So our more recent strategic transportation plan identified the need for the city to develop the Vision Zero program. And in order to achieve our mode share target, we want to use all the available data to us to guide our street safety interventions and prioritize projects based on improving active transportation and subsequently public health. So one type of safety data that we plan to collect in the future would be ER visits and related medical records from partnering health organizations and hospitals. The reason for that is, many crashes that occur on the roadway, especially for active transportation, bicycle and pedestrian crashes, go underreported or just not reported at all to the police. So, when we're conducting crash analysis, we really are missing a lot of that information about where do we have safety problems. Mike talked about using stress as kind of a surrogate measure. I think that's a really cool idea for corridor level studies. And from a big data perspective, we're looking to kind of utilize hospital records to kind of fill in the gaps of those missing crashes so we can identify our safety data going forward better. City of Atlanta also recently adopted legislation to officially become a Vision Zero city, which is the commitment to eliminate traffic deaths and serious injuries, the safe systems approach that Dave was talking about. So that also adopted the NACDA Urban Street Design Guide as our guiding document and implemented a default speed limit of 25 miles per hour on all roadways that are not on our statewide enforcement list. So a lot of our roadways are on a statewide enforcement list where it's written into the law. Here's a list of roads. Here's the speed limit on these roads. And the state gives us permission to enforce speeds at that level. So the 25-mile-an-hour default speed limit applied to about half of the roadways in the city. And the other half will have to kind of work through and go through and do specific studies for each roadway to lower the speed limits, and as they get redesigned or additional safety problems are identified. Another final step for our Vision Zero program will be to develop a full action plan for how we get from our current safety status to a safer to zero. So here's the 6 E's again. The older school approach. I really like the public health way of thinking about things. And, you know, in recent conversations with consultants and planning studies, we've been talking a lot about, you know, crash risk at intersections, differential in speed, and, you know, kinetic energy, different vehicle types, crash hotspots, and all of that stuff. So I want to focus today about, you know, the City of Atlanta's Department of Transportation. It's focused mostly on engineering and evaluation. So we do a lot of equity work as well. My role specifically is on the engineering and evaluation side, so I'll focus on that today. But before we go any further, just to kind of connect the dots with what jobs look like for younger members in the Southern District, I wanted to touch on, you know, what are some of the active transportation job roles that you can hold in the public and private sector. So private sector, typically I worked in the private sector for about 10 years before joining the City of Atlanta in February of this year. Most of the work that I did was either some type of transportation planning, analysis, studies, plans, and design work. On the public sector side, you know, I really chose to come over here because I'm passionate about active transportation and health, and, you know, making our city safer for everyone that uses it. And, you know, there's so many different pieces. The middle column kind of shows the items that, you know, my current job as transportation engineer with the city kind of encompasses. And then the third column on the right is, you know, all these other different areas of things that you can do that are related to transportation, active transportation, and health. So this is all just to say, you know, as we move forward to this Vision Zero Safe Systems approach, there's a lot of pieces, there's a lot of policies, there's a lot of rules, there's laws, all types of things that need to be changed. So it's quite a bit of work, but it's a really exciting time to be in, to kind of be part of that change, to get towards the way we need to be. So to give you a little bit more taste of what my job is like and what I've been working on since I started at the city, I'm going to share some examples from my own work and how it relates to active transportation. And we'll start with a little bit of policy work. So we mentioned FHWA and AASHTO standards before. One of FHWA's standards document is called the Manual of Uniform Traffic Control Devices. I'm sure most people in ITE are aware of it. FHWA has proposed a new edition through a public rulemaking document at the end of last year and kind of the beginning of through this year. So ATL-DOT provided over 100 comments and a couple letters to the Federal Highway Administration regarding the changes to the MUTCD, and the request was basically to give us more flexibility to design roads in a way in our traffic control devices that, you know, provides additional safety benefits, not just real safety benefits, reduce crashes and injuries, but also perceived safety benefits to help to reduce stress levels of people traveling the city, as that affects their public health outcomes as well. We also supported NACTO and APBP consolidating over 500 comments to provide to the FHWA on the MUTCD 11th edition. Some additional work that's ongoing right now in the city of Atlanta, we're developing a policy for where and when to install leading pedestrian intervals. The policy, procedure, and prioritization will all be kind of forthcoming. Our procedure will be based mostly on Toronto's kind of point-based scoring system. And really the question that needs to be answered for the procedure document is, where should we install leading pedestrian intervals? And the answer in my mind is almost everywhere, because the city of Atlanta is a pretty dense urban environment. But we'll look at traffic volumes, crashes, pedestrian activity levels, all types of different factors to kind of identify and prioritize where, we can't install LTIs at every signal in the city immediately. We can do it pretty quickly, but we still need to kind of prioritize which ones we should do first. So we have some big GIS and signal asset management data sets, and we've been coordinating with our state partners that run our signal operations program for a large portion of the city. And from the big data perspective, we have a license with streetlight data for the entire city. So to get our risk model in place where pedestrians are experiencing the greatest delay times, or where there are the most pedestrians, to determine where we should install leading pedestrian intervals, we did a citywide pedestrian activity analysis with streetlight data. You can see that in the bottom right corner of the screen. And it's showing, the higher bars are the neighborhoods that have the most pedestrian activity. So I have a quick, if you want to type in the chat, what neighborhood in the city of Atlanta you think has the highest pedestrian activity? And I'll wait a couple of seconds just to see if you put some responses in here. The bottom left corner is our existing traffic signals with leading pedestrian intervals, and then the middle picture in green, the green dots, is all traffic signals within the city of Atlanta. There's over 1,000 right now, and we currently have just under 100 of them with leading pedestrian intervals implemented. So, all right, so we're getting some guesses. Buckhead, Midtown, 3 points. That may be a 5 points guess. I don't know where 3 points is. Yeah, 5 points. Okay. So looking at the chart in the bottom right corner of the screen here, the highest bar is actually downtown. There's lots of special events, conferences, football games, all types of special events downtown, as well as, our big business community. But even downtown is not the correct answer. I took it out of this analysis in the chart, but the highest pedestrian activity zone in the city is actually the airport. Everybody walking around through the terminals, ground operations, and things like that. I took it out of this analysis just because it, the airport's kind of a self-contained organizational unit that, it's not really a transportation infrastructure as the interior of the city, and it kind of dwarfed all of the other neighborhoods for pedestrian activity through the city. But good guesses. Midtown and Buckhead were pretty close up there, and Little 5 Points is one of our major pedestrian neighborhood centers. So future work that we'll be doing on policy includes our FHWA interim approvals, a lot of things like green paint, bike signals, two-stage turn queue boxes, all these specialized kind of design features for active transportation projects. We need to get approval for in advance of the 11th edition of the MUTCD, as well as doing some requests to experiment to just kind of evaluate whether or not certain treatments are safe. For example, we have a rainbow crosswalk at the intersection of 10th Street and Piedmont Avenue. And, the 11th edition draft of the MUTCD would basically outlaw that. So, we'll be providing some requests to experiment and say, well, let's take a real look at the safety numbers here and see, I don't think that a rainbow crosswalk is distracting to people that causes them to crash. I think it, forces them to slow down and be more aware of pedestrians crossing the street. So design, I'll go through these slides pretty quickly just because we're getting close on time. We've been incorporating our active transportation projects, bike lanes, pedestrian sidewalk improvements into our resurfacing projects that we have grants from the state on. So I've completed a few of those projects to date, and those will be under construction starting soon. Another item that we need to work on is developing specs, pay items, and special provisions for all these specialized treatments that are not in our construction system. So I wanted to focus mostly on the analysis and studies because I think as we move projects along, understanding not just, instead of taking the reactive approach of, oh, here are a problem intersection that has a lot of crashes, has a lot of injuries, unfortunately has fatalities, and trying to fix that. As we were designing projects, we were trying to now take a look at, okay, what are the different design options and how can we maximize safety of alternative transportation users based on that. So one example is DeKalb Avenue. If anybody on the call is from the Atlanta area, I'm sure you're aware of DeKalb Avenue. There is a groundbreaking for a reversible lane removal and resurfacing project being held today, right now. But there's a future phase of the project that calls for more complete streets. It was kind of separated into two projects for budget and schedule reasons, but the consultant had delivered to us a draft concept report that identified a few different design alternatives for bike lanes along the corridor. One was kind of a north side alternative, one was kind of a south side alternative. And we realized that we hadn't really done a detailed dive on what are the safety implications of these different design alternatives. So we did a little bit of back of the envelope analysis to kind of look at the number of conflict points and type of severity for each of the design alternatives. This is showing kind of the north side alternative, and it's a trade-off question. Do we want the cycling facility that has more conflict points that each have a lower severity, or do we want, this is kind of a figure from the AASHTO Guide for Development of Bicycle Facilities, where you have a shared use path adjacent to a roadway. That kind of explains some of the conflict points inherent with certain types of bike facilities. Or do we want a alternative where there are many fewer conflict points that are higher severity, like for example, crossing the main road, but could potentially be mitigated by other traffic control measures, raised crosswalks, rectangular rapid flashing beacons, etc. So we did a quick analysis on that. The consultant is going through and really diving in deep and actually proposed using speed differential and potential for kinetic energy transfer in combination with risk and traffic volumes, conflict points, to kind of do a very detailed dive on which of these design alternatives is safer. In another project, we sort of did the same type of analysis in-house for a project where we're trying to connect two different bicycle facilities from south to north. So if you look on this page, we have a downtown project that's to the south is the left of the screen. On Piedmont Avenue, it's a left side one-way protected bike lane. And then on the right side of the screen, you have a right side protected one-way bike lane. And in the block in the middle is between Ponce de Leon Avenue and North Avenue. It's a state route, so permitting requirements and things like that are kind of separate. So we're trying to look at what's the best way to connect these two bike facilities through the state route block. So we'll focus a little bit in on the intersection on the right at Ponce and Piedmont. So this would kind of be the no build option, which has obviously a high level of exposure where bikes are just kind of sharing the roadway as they approach. But we also looked at a number of different design alternatives: 2-stage turn, queue boxes, a diagonal crossing with an exclusive bicycle phase, bike box option. We looked at integrating some protected intersection design features, because one of the roadways is one way in the space, which gives a little bit of extra room to do some protected intersection features. We gathered a ton of data from streetlight data. We looked at bicycle and pedestrian activity, gears, crash analysis, speed from various sources, and kind of used all of this. It's kind of a, most traditional traffic analysis projects and studies just look at motor vehicle delay and level of service, and that's kind of the metric. And then maybe there's like a paragraph that says, installing a bike lane is good for bikes, but it doesn't really go into any detail. So we have all this big data now, so we really went into a lot of detail to see, what are the safety implications of these different design alternatives. We looked at individual conflict points, and what severity they are, what's the projected bike and vehicle volumes at each of those conflict points, and kind of use that to come up with these different scores. We looked at vehicle delay, conflict points, a risk score, bicycle level of traffic stress, and bicycle delay, which is not something that's typically provided. And then we normalize those values to recommend a preferred alternative. So that's all I wanted to show on the project analysis side. Just that the city of Atlanta, while we still have a long ways to go in changing our processes and approaches to a safe systems approach, we're kind of taking steps in the right direction to try to maximize our active transportation mode share to improve public health throughout the city.
All right, thank you, Chris. I do want to say a big thank you to all the presenters for presenting in your field and doing it in a timely manner, so we have some time for some questions. So I'll shift it over to Melissa to kind of monitor the questions and kind of deal with that portion.
Yeah. Hey, everybody. I'm Melissa. So I've been keeping track of the questions. We got a few really good ones. I think the first one I just kind of wanted to pose to Chris. Being the only public person who's kind of on this call, what are some of the biggest roadblocks to implementing some of these Vision Zero projects? You're on mute. Okay.
I think some of the biggest roadblocks, previously, it was definitely data availability. But, as our new big data tools start to come in, we really have the ability now to do the type of analysis that we need to do to promote active transportation projects. I would say probably now the biggest is just, changing policies, changing Atlanta City Code, changing Georgia state laws that doesn't allow us to reduce speed limits below 25 miles per hour. I think it's just kind of, it's like turning around the Titanic. From the way that we've designed, analyzed, and planned transportation systems for the last 50, 60, 70 years.
Yeah, that makes sense. Thanks for that. I think the next question is going to be directed towards Tyler. I think Ron asked how you envision the healthy mobility model becoming, or do you even envision it becoming part of the traditional planning process that people go through?
Thanks. Yeah. This is one that's come up. I know when we've talked, when I've talked internally with our teams at VHB, I think that it's kind of twofold, right? I think that first level of analysis of just kind of the existing conditions, what are the health kind of projections and what's going on there today, is something that we envision could be incorporated into every project we do. We've even talked about, as we open a new project number, as we open a new even proposal number before we even have a project, we have an understanding similar, just like it's in GIS, it's updated as the census is updated. So that data is available just when you're looking at existing conditions, same way that you would look at, you know, are there sidewalks, or are there wetlands, or are there threatened and endangered species? You would look at what are the health conditions. The second level, really getting into the individual characteristics, is one that we found isn't appropriate for every project that we work on. Some projects are too small, some the data isn't quite there, or some they're really looking at, you know, other things. Looking at what facilities to put in a regional park, for instance, is one that we looked at, but decided, you know, we weren't going to get anything kind of value out of it for something like that. But in terms of that first level of understanding just what the risks are for a community, I think that that's something that, just looking at existing conditions, at least, you know, we at, you know, VHB in Orlando in our studio are doing on every project that we're working on now.
Nice. Zir, Mike, I saw that you and Ron were having a bit of a dialogue in the chat. I kind of wanted to follow up a little bit on that. You had talked about how you're getting ready to try to move this out and push it out to the masses. What are some of the applications that you see once it does kind of go out public facing? You know, will it be used for revising design criteria, or anything like that? What are
Yeah, that's a great question, Ron, and I appreciate you kind of elaborating on it a little bit too. And to be fair, there's lots of different specific outlets for transportation in general. So it could be in initial scoping, it could be in project prioritization. To your thought, we are starting to try to use it now for best practice modifications. So where historically, you know, a lot of our best practices that we refer to, it's all if then else statements. If you've got this, then this might be the best, and then we hit play basically. And what we're finding is that's not the best kind of approach for being human centric. And so, yeah, we are looking to start to modify best practices based on that. Now, what it could be used for is kind of the sky's the limit. We've got lots of folks that are showing interest, not even associated with the transportation industry. So we've got health professionals looking to roll it out into hospitals. We've got industrial clients looking to see what you know, emotional stress can do to mistakes being made in production lines. Even monitoring, you know, a retirement community, so you can see when an aging person that you care about stresses out that day. So there's lots of other things in the cooker for it, but for transportation in particular, I think the best use of it is bleeding edge front of the project through planning. Once you get through planning, though, it should be your decisions are made and design can go unfettered. Hopefully that answers your question. But for Ron in particular, he was asking about, you know, what's the next steps for making this a tool that everyone has access to. We're still kind of in the testing with specific partners now, but if you are a specific partner or want to be a specific partner, please reach out via email and let me know. We're using it on lots of our projects, lots of our, especially in kind of the earlier phases of responses right now, and it's telling us lots of really cool stuff about how users are going to respond.
Thanks. The next question / comment is directed toward David. I don't know if you missed it during your presentation, but you know, Ron really said, you know, this is an outstanding presentation. Thanks for reminding us where we came from. That is regarding the role of civil engineers in public health some 90 years ago. I wanted to follow up on that a little bit and ask if you, as a public health professional, have any specific courses, materials, books, etc., that you would suggest that engineers familiarize themselves with to help shift the mindset towards, you know, just data and looking at it more as a public health professional?
That's a great question. Man, so at Georgia Tech, we had a transportation and health course. And if you, I'll put it actually in the chat, but there's a transportation public health clearinghouse. And literally, I think Tyler mentioned that Richard Jackson's book on the built environment and health is great. So if you type in Richard Jackson built environment and health, it'll come up. But I mean, I wouldn't read too hard into it. just think about health and think about, see Ron followed up about focusing on people rather than vehicles. That's a good way to do it, right? Don't worry about crashes, worry about injuries. That's public health right there. That's all you really need. If you're not, okay, if a car gets banged up, that's bad. But what we're really worried about is people getting banged up, right?
Yeah, for sure. I think, we're coming to the end. I'm sorry for everybody that, I think that the presentations were really great. And I think that we did a lot, letting them kind of roll through and get through all their material. There was one other quick question about if anybody's using big data to look at like harsh braking and acceleration. I don't know if any of the presenters on this call have looked into that. Paul mentioned that, and I think that would be a really cool thing to look at that I hadn't really heard yet in this format.
So I'm not looking at it in terms of from health. I also think that that's a great idea. I know that our applied technologies team that knows way more about this than I do is looking at data that they have from cars and cell phones in terms of where people are going and how they're getting there and that sort of information. So I'm wondering if that's something that would come from that data set as well. And I actually saw it in the chat and I made a note to reach out to our folks on that already, because I think that would be really interesting too, especially overlaid with some of the other data.
Yeah.
I think here in the city of Atlanta, we're not using that data yet, but as part of our Vision Zero action plan, we do have a kind of a portion of the budget dedicated to surrogate safety measures, which includes those harsh data braking events. I know some providers like Ford has a kind of fleet of connected vehicles that you can pull that information from, as well as a company called Wejo that kind of aggregates that connected vehicle data and then shares that out through their subscription service. But we're not quite there yet, but probably coming soon.
Cool. All right, well, we're a little bit over time, so I'm going to do one last question to all the panelists. In one sentence or less, what is the key takeaway that you want the audience to get from your presentation? We'll go in the order, start with Tyler.
Perfect. I just think kind of going on Dave's thing, it's that the decisions that we make as planners, engineers, and designers have impacts that go well beyond just how fast a car gets through a corridor. And I think just having that mindset as we're doing our day-to-day tasks is super important. However we measure it is fine, but I just think that mindset's important.
All right, Mike.
Hey, I'm with Dave. I think we're not doing as good of a job as what we can to design for real people. We've been taught to design for cars. That's what we all came up and we're learned capacity-driven design. It's not working, and we're not doing our job if we continue to do just that.
Dave.
Epidemiologists don't solve epidemics. Engineers do.
That's very good one sentence. All right, Chris, take it out for us.
I would just say it's a really exciting time to be in the transportation industry. If you're a young member and you're kind of considering looking at active transportation, push your employer on it. Tell them, you say, look, I'm a member of the NSPE or ITE, and our creed, like the first thing on this sentence is, engineers should protect the public health and safety of everyone on our transportation system. So I think it's an exciting time. It's a fun time to kind of be part of the change to increase public health and active transportation throughout cities across the US.
Yeah, I agree. And yeah, for young members to really kind of be the change, and you're going to grow up and be the next leaders. So it's exciting to see that. All right, well, with that, I think we're going to end it and stop recording. Huge thank you to all of our panelists who came out. That was a super exciting presentation. So I think we're going to go ahead and end it here. Thank you so much, guys. Okay.